which is very important point to know, and it's very important actually when you do your diagnostic procedure intervention. Then next, you can get the SMA, which is superior mesenteric artery, and superior mesenteric artery has anterior takeoff as well. And then you have the origin of the left and right venous artery. Then you get the gonadal arteries, and finally, the inferior mesenteric artery, which has again anterior takeoff. Then at the end, you get convoluted and external iliac arteries. So whenever you talk about mesenteric ischemia, it refers to small intestine ischemia. It can be secondary to occlusive or non-occlusive disease. The ischemic symptoms can be either acute or chronic. Usually acute ischemia due to arterial thrombosis, embolization, or venous thrombosis, whereas chronic ischemia is due to atherosclerosis. I strongly believe mesenteric ischemia is underdiagnosed. I think it's more common than what we think, especially patients with septic shock, patients with prolonged hypertension. I think a lot of these patients, when they get septic, most of the time it would be mesenteric ischemia. And again, it is underdiagnosed or misdiagnosed. It is considered to be rare in the US, but I think it is more than what we think. The prevalence currently is estimated between 0.09 to 0.2% of all admissions in the United States. Again, this is the different etiology and epidemiology of mesenteric ischemia. Again, mesenteric artery embolism account for the majorities of mesenteric ischemia, which is 50%. And you see it in patients with cardiomyopathy, with ischemic or non-ischemic cardiomyopathy, patient with atrial fibrillation, regardless of what the ejection fraction, recent diagnostic procedure, such as heart catheterization or any peripheral intervention, which potentially actually atherosclerosis emboli. You see it in patient with vasculitis or patient with vascular disorders, and this again accounts for 50%. Mesenteric arterial thrombosis accounts for 15 to 25%, and usually you see it in patient with atherosclerosis, patient with peripheral arterial disease, patient with hypercoagulable state, females with estrogen therapy, and patient with prolonged hypotension, either because of sepsis or patient because of hemorrhage or cardiac shock. Mesenteric vein thrombosis, we see it mainly in patients with inflammatory bowel disease or hypercoagulable states, and this accounts for 5% of the cases. Now, non-occlusive mesenteric ischemia, usually due to spasm. You see it in patient with peripheral arterial disease, patient with septic shock, patient with cocaine use, and patient with hemodialysis, and this accounts for 20% of all the cases. Now, as far as the pathophysiology, most of you know that celiac artery supplies the liver and spleen. I'm sure that in the first slide you see the hepatic artery, the splenic artery. SMA supply the small intestine, and IMA supply the colon. Now, here are the risk factors for mesenteric ischemia: advanced age. Patient with advanced age, they have more atherosclerosis, and most of the chronic patients with chronic mesenteric ischemia, I see it in older females with tobacco use and multiple risk factors for atherosclerosis. Say a patient with hypertension or patient with hypotension in case of shock. Patient with coronary artery disease, congestive heart failure, valvular heart disease, especially in the setting of endocarditis, patient with atrial fibrillation. Hyperlipidemia, obviously, is a risk factor. Tobacco use, another risk factor. You see it in patient with inflammation such as pancreatitis and diverticulitis, patient with abdominal injury, patient with renal failure. Recent catheter studies, as we mentioned earlier, either for coronary or peripheral procedures, cocaine use, and clotting disorder, including estrogen use. Now, acute mesenteric ischemia, usually patients they present with abrupt, severe abdominal pain, bowel urgency with fever, nausea, and vomiting. Whereas patients with chronic mesenteric ischemia, usually their symptoms kind of subtle. They present with abdominal, what we call abdominal angina. Usually they get abdominal pain 30 minutes after eating, and the pain usually gets worse over 1 hour, and it will go, the pain will go away after 3 hours. And most of the patients will have cachexia with significant weight loss. Now, how you put the diagnosis of SMA or mesenteric ischemia? One CT scan, and here you can see in this slide we have extensive atherosclerosis in the abdominal aorta. This is longitudinal, this is transverse section. As you can see in this slide, the celiac artery is totally occluded. The mesenteric SMA is heavily calcified with severe stenosis. You can see it in both. Other methods of diagnosis of SMA stenosis is MRI. And again, this is the spine, this is the abdominal aorta, and you can see severe stenosis in the proximal segment of the SMA. CTA is another modality, and you can see here the patient has severe stenosis in the proximal SMA. Here's another case where you see actually 100% occlusion in the abdominal aorta. The patient has patent celiac artery, the SMA, you have a abrupt occlusion here with significant clot burden. This is typically what you see with SMA thrombosis. In my opinion, the best way to address and diagnose SMA or celiac ischemia is angiogram. Again, it's very important to decide which axis you are going to do. Again, femoral axis has some advantages and disadvantages. Most of the time now we do angiogram. If we're going to just diagnose it, we go from the radial approach. But if we have intention, if we have diagnosis ahead, and we have intention to do angioplasty or intervention, it would be nice to proceed with femoral approach because most of the time you need maybe 7 French catheters, especially in females, it would be too big for radial approach, so we go with femoral approach. As far as diagnostic procedure, most of the time 4 French or 5 French catheter would be enough, but for intervention, you are going to end using either 6 French or 7 French catheter. So what we do usually, after we get the axis, arterial axis, we do abdominal angiogram with digital subtraction. So what we do, we start with pigtail catheter, which has side holes. We put it at the level of L1, L2, and then we do 2 views, either AP view, which is optional, but the best actually way to look at the ostium of the celiac artery in SMA to proceed with lateral view, as we showed earlier in the first slide, because both celiac, SMA, and IMA, they have anterior takeoff. So for lateral view, you have to keep in mind that the patient arms will be in your way. So it's very important to remove the rails of the cath lab table. You have to ask the patient to raise their arms up. And since you are going to do digital subtraction, you ask the patient to take a deep breath, then they have to exhale completely, then you take the picture at that lateral approach with digital subtraction. Then we do selective angiogram, and there are multiple ways to do selective angiogram. Convoluted catheter, my favorite catheter is IMA catheter or HEMA catheter. It has a sharp angle. It's very easy with this catheter actually to selectively cannulate the SMA and celiac. And again, keep in mind, both arteries, they have anterior takeoff. Just to give you an idea how we do this procedure, I'll present 2 cases, then we'll show you some slides, some actual pictures of case number 2. This is how the patient may present. Case number 1, 76-year-old female. She presented with sudden onset of the gastric pain. Actually, it was thought that the patient has acute coronary artery syndrome with inferior ischemia. That's what they thought when I received phone call from the emergency room. So she was admitted to the hospital actually for chest pain, rule out acute coronary artery syndrome. She had past medical history of presbyteral angina with hypothyroidism and previous history of coronary artery disease. Her medication included aspirin, simvastatin, and she's in thyroid replacement therapy. During her hospital stay, in the first 24 hours, she had serious cardiac enzymes, she had EKGs, and we ruled out acute coronary artery syndrome. And she had typical symptoms of abdominal pain and abdominal angina, and her pain was mainly shortly after she eats. So we did CT of the abdomen, which was extensive vascular disease involving the abdomen and pelvis. She was found to have abdominal aortic aneurysm, measured 3.4 centimeter, and she has severe stenosis in the celiac and superior mesenteric artery. So what I did in this case, I knew that she has significant stenosis, and I knew that we're going to need larger catheter, most likely, in order to perform my intervention. So I started with 6 French, right femoral artery axis. We did abdominal aorta with pigtail with lateral projection. I selectively cannulated that celiac artery and SMA with the 6 French Lima catheter. I confirmed the diagnosis. Then I was able to identify the size of the arteries. That the celiac artery is very large, about 7 millimeters in diameter. So I knew that 6 French catheter would not accommodate, or I would not be able to deliver my stent. So in this kind of situation, I upgraded my system to 7 French guide, catheter, and sheath. Then what I do routinely, I go with stiff wire, and Sparta-Core has floppy tip, and it's very good wire actually to support the balloon and the stent. Then the rest of the procedure is very simple. I went ahead and put 6.0 by 14 millimeter express stent, which is actually balloon expandable stent to the SMA, and another 7.0 by 15 millimeter express stent to the celiac artery. Procedure usually is very easy, quick, doesn't take more than 15 to 20 minutes to do. Here's another case, 83-year-old female who presented with chronic abdominal pain, and she has significant weight loss. Her symptoms have been going on for about 6 months. Actually, this patient has extensive atherosclerosis. She has peripheral vascular disease. In fact, just recently, the patient was found to have significant subclavian stenosis. I fixed both left and right subclavian artery percutaneously. So this lady, she has vascular history of coronary artery disease, peripheral vascular disease. She had previous intervention to her left SFA. I performed in the past atherectomy with BT and stent. She has abdominal aortic aneurysm, she has paroxysmal AFib, hypertension, hyperlipidemia. So essentially, she's vascular path. She has previous CVA with TIA, she has chronic kidney disease with tobacco use. Her current medication and later on for AFib, she's in thyroid replacement therapy, she's in Tropol, Losartan, and Lubiprene, which is calcium channel blocker, and she's in dual antiplatelet therapy since she has previous procedure for peripheral limb ischemia with combination of clopidogrel and aspirin. CTA of the abdomen showed intrarenal abdominal aortic aneurysm measuring 3.4 centimeter. She was found to have 100% occlusion in the right uterine artery with atrophy. The left uterine artery is patent, and she was found to have severe stenosis in the SMA, which explained patient weight loss and abdominal pain with abdominal angina. Again, we went with 6 French, right femoral axis. I did abdominal aorta, angiogram with pigtail catheter, and usually we use very limited amount of dye. Usually I use about 20 cc of dye, and again we do digital subtraction images with the rails out, arms up with the exhalation. I did selective angiogram utilizing 6 French IMA catheter. Then I have to upgrade to 7 French to be able to put my stents. Again, we use short Lima guide, Sparta-Core wire with extra support to be able to deliver my stent. Then I did 6.0 by 14 millimeter express stent. Again, the procedure doesn't take long. I'll finish this with the picture of this last case. And again, this is the femoral axis. As you can see, the patient had extensive peripheral vascular disease with extensive calcification. And the femoral artery has a lot of disease. The external iliac is calcified. She had totally occluded internal iliac artery. And the common iliac artery has extensive atherosclerosis with 90% stenosis. Actually, to be honest with you, after I did the SMA artery, actually I put stent here in the iliac artery on my way out. So it was a challenge to go through this, but it was relatively easy. I went with hydrophilic coated wire, which is B18 wire. I was able to cross this area, then I put long sheet. And another challenge, here in this view, you can see the patient has intravenous abnormal aneurysm. I calibrated the SMA, it's selective angiogram, with the IMA catheter, and as you can see, the patient has 90% stenosis in the onset of the SMA. So what we did angioplasty with the balloon and stent, and we had excellent result. And as I said earlier, in my way out, I was able to address her right coronary with the balloon and stent. Thank you very much for allowing me to participate in this conference. I'm honored to be part of the speakers of this excellent symposium. Appreciate your invitation. Thank you so much.
Thank you very much for the first talk. Since it's recorded talks with the discussion for later on, and it's my great pleasure to introduce another next speaker. Dr. Manar is one of the organizers of this nice meeting and my fellow in the scientific committee. He's going to highlight the importance of multidisciplinary approach to the diabetic foot.
Yeah, thank you very much for the invitation. I want to speak about the old subject, which is diabetic foot. I think many of my colleagues, they covered this subject yesterday, but again, this is an important subject in the region because majority of the patients, what we see, they are diabetic and they have somehow diabetic foot problem. I have no disclosure to the subject. Of course, the aim of the multidisciplinary approach is the treatment of the existing condition, prevent or secondary prevention for any other lesions which may happen in other part of the body, prevention of the recurrences of the lesion, and also primary prevention so that patients, all diabetic patients, they will not have diabetic foot problems. As we know, the etiology of the diabetic foot disease is covered by three main subjects. It's in neuropathy by 55% of the cases, arterial component 10%, and a combination between arterial and urogenic is approximately 35%. If we understand this etiology, it will be easier for us also to treat the case according to the etiology. Of course, we are dealing with a large number of diabetic patients. It's millions of populations in the world. Of course, the statistics are varied between 12 to 25% of the diabetic patients, they have foot problem. In fact, in the lifetime risk of developing foot ulcers in diabetic patients is approximately 15% for more diabetic patients. Unfortunately, 14 to 24% of the patients who have diabetic foot problem, they ending up by amputation, minor or major amputation. The incidence of charcoal foot, which is considered like a serious complication of diabetes, is approximately reported at 7.5% of all diabetic patients. We have several classifications for the problem of the diabetic foot. We use the widely introduced classification according to the International Working Group on Diabetic Foot Risk Classification to grade 1 to grade 4. We have the Wagner classification of diabetes, and we have also the University of Texas Diabetic Foot classification. So we have several classifications to classify the diabetic foot problem, and but important for everybody to use a standard protocol to classify the patient according to severity of the case. If we go for the polyneuropathy problem, we should know that 78% of the patients with diabetes, they develop polyneuropathy. This problem is progressive and irreversible with all means of the treatment, which introduced by internal medicine. Sensory neuropathy is a serious issue. The patient reporting about numbness, paresthesia, hyposthesia, or even dysesthesia. Motor neuropathy can lead to muscle atrophy, it can lead to motor defects, and it's ending up by dystrophy or destruction of the whole foot. The autonomic neuropathy also is a serious issue. Patients reporting about dry skins, which can lead to cracks and also infections. Of course, the standard examination should include several ways of examination. Even if you are a vascular surgeon, you should know about this way of investigations. Is not necessarily need to be done by neurologists. This important is the examination of the vibration sensation, which can make the diagnosis of diabetic polyneuropathy. Of course, our aim is to treat the peripheral vascular part, which is like 45% of the cases, and the standard, of course, care is to do the clinical examination, to document all the pulses, do ankle brachial pressure index. I know that it's not recommended in diabetic foot, but you can try to get numbers. You can depend on the arterial duplex ultrasonography, which can give you an idea about the pulse curve analysis. The skin perfusion pressure measurement is also the toe pressure measurement is important, and also if you have facilities of the transcutaneous oxygen pressure measurement, you can use these tools to make the prognosis and the examination of the patients. The indication for vascular intervention usually is a clinical examination. We observe the wound healing. We depend on the toe pressure. We depend on the oxygenation. That's important tools to decide if we do intervention or no. We have also some factors which play a role in the prognosis of diabetic foot, like cooperation of the patients, some biomechanical factors like presence of post-traumatic arthritis or degenerative arthritis that can lead to also deformity of the foot. Compliance of the patient is important, and also the psychiatric condition of the patients, which we need to talk. So it is a multidisciplinary team and approach to the problem. We need endocrinologists, we need the help of podiatrists, and also orthopedic surgeon. In conclusion, apply a protocol for classification of the diabetic foot disease, use multidisciplinary approach and treatment of diabetic foot disease, and also preventive protocols need to be put in every diabetic clinic. Thank you.
Thank you very much, Professor Bonar, for a great presentation and a great lecture about a very interesting topic. Let me take the chance to introduce the next presenter, which is Professor Maher Khatoum from Germany, who is going to speak about carotid stenting, a new technology. Professor Maher.
Thank you for the nice introduction. I'm a doctor, I'm not a professor. Thank you very much for the nice invitation. I will speak today about the transfemoral stent angioplasty of the left internal carotid artery with truncus bovinus. This is my disclosures. Truncus bovinus is a common variant of the supraaortic arteries, and in the textbook of anatomy is reported about 10 to 15%, but in the reality we know, as we usually see, is more common. It's much common. The stenting of the left internal carotid artery has a difficulty in the cannulation of the left common carotid artery with truncus bovinus, and the difficulty is also with bringing the sheath and the material in the lumen of the common carotid artery, and that causes more friction, longer fluoroscopy time, longer operation time when we require an alternative access. Routinely we see during the intervention that the greatest challenge is not the cannulation of the common carotid artery, but during the intervention, we routinely see, that's the video. Can we play the video, please? We can see that when we switch to a stiff wire to bring the sheath into the lumen of the common carotid artery that slip with the catheter with the sheath out of the common carotid artery. As an alternative, we have the brachial arteries, but as a surgeon, I will prefer the safety. With two-wire technique, it's easy to cannulate the common carotid artery that for bring less friction, safe placement of the sheath in the lumen of the common carotid artery, and avoid the involvement of the other arteries supplying the brain, and keep it distant to radiation generator. And for me, is very important because I perform this intervention in local anesthesia, that the right hand remains free for neuromonitoring. And in the hybrid operation room, the transfemoral access offers better radiation protection. The material I need for this technique, long 7F sheath, for example, Cook 70 or 90 or both, angiocatheter, for example, hockey stick shape, 2 rigid O35 guide wires, for example, ambulance wire with short soft tip, and embolic protection system, stents and balloons, etc. The stages of this technique: at first, cannulation the truncus brachiocephalicus, then cannulate the right subclavian artery and switch to the first stiff wire, then advance the long sheath, the tip of the long sheath, close to the ostium of the common carotid artery left, and with the catheter, our choice, cannulate the common carotid artery into the external carotid artery and swift to the second stiff wire. Then withdraw the first stiff wire and advance the long sheath into the lumen of the common carotid artery and place our material as we know, the protection system, stents, balloons, and etc. For example, the first case with MOMA system, the second case with filter wire. I see another slides for me. Here, as you see, road saver with MOMA system. The second case, here balloon angioplasty after stenting. The end result with intracerebral angiography. The second case with wall stent and angiography. I have been using this technique since 2011, and I have treated 57 patients with it with 100% success. No stroke, one single recurrent, even retreated with angioplasty balloon, only with angioplasty balloon. And this is the statistic what I want to see. I want to show. The fluoroscopy time is about 10 minutes. The open time about 38 minutes. We see the summary of this technique. That's also video. Can you play the video? Play the video, please. As we see, at first, cannulate the truncus brachiocephalicus, then the right subclavian artery with soft wire and angiocatheter, then swift to the first stiff wire, then advance the sheath to the ostium of the left common carotid artery, and with a catheter, cannulate the common carotid artery and the external carotid artery, swift to the second stiff wire, then advance the sheath withdraw, first withdraw the first stiffware, then advance the sheet in the lumen of the common carotid artery and place our material as we know. Thank you very much for your attention.
Thank you very much, Dr. Maher, for this new technology. I think we'll take the discussion to the end. I know that you have presentation in the room. You can just go there and come back for the discussion. Thank you. Thank you. I think we'll move on to the next speaker, Dr. Samer. Is he here? Yeah. Dr. Samer is a well-known now after 2 days of the conference, and he will present us for the endovascular creation of AV fistula new devices.
Yeah, good afternoon, and thank you, Madam, for inviting me. I'm going to talk about the new devices now for AV fistula. I know as a surgeon we may hate this procedure because we know AV fistula is a very nice procedure. You can do it local, takes maybe 30 minutes. But my advice, get your hand on this device if you're not convinced, because otherwise intervention in cardiology will take over. And then in maybe 5-10 years you don't see any surgical AV fistula. So even if you're not convinced, I think at least you get trained and don't let it be done in your hospital without your involvement. Because with the time, I think it may take over. We have two available systems in the market. We have ellipsis from Medtronic and we have a wavelength from Bar. And both require specific anatomical inclusion and exclusion criteria for successful procedure and outcome. Both require really intact arterial system, which is common sense when you do any AV fistula. You need negative modified allen test and triple flow using ultrasound. But the key anatomical factor in this procedure is the perforator vein. If you don't have perforator vein, it's not going to work. And you need at least one stable outflow vein for fistula, which could be basilic or cephalic, and should be more than 2 millimeters using a tourniquet. And of course, you should have a patent central venous system. Let's start with the first system, which is the wavelength from Bar. Again, anatomical criteria specific for wavelength is you need a perforator, as we said before. You can use radar or ulnar artery with radar or ulnar vein, but both you have to be at least 2 millimeters at the anastomosis location and the axis. The distance between the proximal radar or ulnar artery and vein, the distance where you can create the anastomosis, it should be less than 1-2 millimeters. Otherwise, you may end with the aneurysm or perforation. And you can go either parallel or anti-parallel situation. To give you some tips, the full French has 2 catheters. The arterial catheter can go through brachial radar or ulnar artery, whereas the venous catheter, which has electrode, you can go through brachial radar or ulnar vein. It requires a fluoroscopy and contrast material injection. The magnet usually hold the artery and vein together, whereas the radiofrequency electrode creates the anastomosis. Most anastomosis happen between proximal radar or ulnar artery with the vein, and we know that we have double vein, lateral and the medial vein with the radial ulnar artery, which usually the lateral radial and ulnar vein are the more common suitable for the anastomosis. The location of the anastomosis should be very close to the perforator, so you can direct the blood flow to the superficial system, and sometimes we have to coil the brachial vein to enhance the flow to the superficial system. This is how it works. This one we went through the radial artery and the brachial vein, one antegrade, one retrograde. You can go either way. This is the 2 arterial and venous pectoral load. Here the electrode being released, and after we fire, you see the fistula. But you can see the flow mainly in the deep system, so we have to coil the brachial vein to augment the flow to the superficial system. The most access creation site for the AV fistula usually in the radial artery, radial vein, then less common is ulnar artery, ulnar vein. The axis for the arterial usually mainly is the radial, then follows the brachial, and less common is ulnar. And the same for venous axis, usually is the radial vein, brachial, and less common is the ulnar vein. How good is this system? This is a neat study. They look at, they have like 80 patients. The success rate was about 98%. Physiologically suitable by ultrasound only is about 87%, but suitable for cannulation was only 64% in 3 months. The patency, the prime patency, about 1 year, 69%, and 84% was secondary patency. So what they conclude that Everlink, which later on become Wavelink, demonstrate high 12 months cumulative patency with minimum complication. It may be viable alternative option for achieving pertinence AV fistula. Then we have an EVSS study, which is more, it's published like 2 years ago. And this multi-operator, single center, single arm prospective study. They have more patients, 32 patients. They use an Everlink, again, become wavelength. Success rate was 100%, but cannulation was able to achieve in 3 months about 78%. The primary patency was 83%, and the cumulative patency was about 87%. So what they conclude, again, excellent procedure success with low rate of complication, high rate of function, cannulation success, and patency without the need for additional post-operation intervention. Then we have a multi-center single-arm trial. It's a prospective trial published this year, March. They have primary patency at 6 months was about 70%, time for maturation about 41 days, and the device-related serious adverse event was only 2%, but arterial or venous access complication was almost 0%. So then we move to the second device, which is the ellipsis from Medtronic. Again, you need a perforate that has to be more than 2 millimeters. Here, you just look at the proximal arterial renal artery lumen should be more than 2 millimeters. So here, you just want to look at the proximal renal artery. You don't care about the axis side, because this is a direct puncture. So the renal artery anastomosis should be more than 2 millimeters, and the distance between the perforator and the proximal renal artery should be less than 1.5 millimeters. It's a single superficial venous guide wire advances through the perforator all the way to the proximal renal artery. You need a duplex ultrasound lead here for fluoroscopy. You don't need a contrast. And the device advances over the wire, captures the arterial and venous wall, and then activate it, and then you have the fistula, and then you do ballooning. Is the way it works. You go through the perforator. The perforator has to be straight. You go over inside the proximal renal artery. Then you get a device, close the device, activate it, and then balloon it, and you end with a fistula. It's a single catheter with a thermal energy. Again, perforator should be straight. Anastomosis you create at the level of the perforator. It's an advantage over the wavelength. And the location is more cranial. So that means if you did a wavelength and doesn't work, you can still do the ellipsis because it's more cranial and it's more proximal anastomosis. How good is this device? This is again published recently. It's a single center prospective cohort study. They have 234 patients. Success rate was about 99%. Primary patency about 54%, but secondary patency went up to 96%. So when they conclude, ellipsis pertinence fistula allowed for rapid and safe creation of a reliable autogenous axis and should be considered the next preferred axis option. See, they're starting now to tell us we should start this one even before surgery. Then we have this study, again published recently. They compare both devices, wavelength with ellipsis, and they found no significant difference in primary patency between both devices. But when they look at the cumulative patency, it was better for ellipsis versus wavelength. So when they conclude that both techniques they have a good success rate and adequate flow volume, but when you look at cumulative patency at 12 months was higher for ellipsis than wavelength. Then they compare the surgery versus percutaneous AV fistula. This is the time we start getting worried about it, because now they try to tell us it's even better than surgery. And look at that. When they look at this is a single center prospective review. They have 107 patient ellipsis and 107 patient had a surgical AV fistula. And they look at primary patency at 1 year was much better for surgical group. But then when 2 years was no different. When they look at the secondary patency at 1 year, it was no different, and 2 years was no different. So they conclude that superior maturation rate for percutaneous AV fistula, similar rate of percutaneous intervention. However, the surgical fistula had required more frequent surgical revision and low risk of infection with the percutaneous AV fistula with low risk of steel and aneurysm formation. So they conclude that percutaneous AV fistula, although minimally invasive, have results comparable and in some respect superior to the surgical AV fistula. So what our algorithm, or what the algorithms they recommended, that you always start with a radiocephalic AV fistula if we have a good vein. If it's not, really we use an ulnar basilic AV fistula. If it's not, then to go to wavelength. If this is failed, you go to the ellipsis because it's more cranial. And if this one failed, you finish from forearm, you go to the brachiocephalic AV fistula, and finally you go to brachiobasilic AV fistula. So in conclusion, endovascular AV fistula has high technical success with minimum complication and high 12 months cumulative patency. It reduces the vessel trauma, lead to a better fistula formation and potential decreased morbidity and improve patient acceptance. And it may be a viable alternative option for achieving AV fistula for hemodialysis patient in need of vascular access. Thank you very much.
Thank you very much, Samuel, and thank you for a good message to young surgeons. It takes me a great pleasure to present the next presenter, Professor Bajim Patel. He is a consultant vascular surgeon in Queen's Mary University. He's been involved in a lot of the Royal College training courses, and he's going to tell us about training challenges of vascular surgery. Professor Bajim.
Thank you, Mr. Chairman. Good afternoon, ladies and gents. I'd like to thank the Emirates Vascular Surgical Society for giving me this opportunity. It's a real honor and privilege to be here. I've got nothing to disclose. And just a slight correction, I'm an alien over here. I'm not a vascular surgeon. I'm a professor of surgery with clinical interest in laparoscopic and upper GI surgery, and my academic expertise is technology-enhanced acquisition of surgical skills. I work across different specialty, developing training curriculum and programs and implementing competency-based training. So we will talk a bit about this and as applicable to vascular surgery. Now, training by surgical simulation is now well embedded and accepted and has been influenced by aviation and military sector. In the West, our stated method of training, which is learning by doing, is no longer acceptable, and it's not a competency-based training model, so it's not fit for purpose and needs to be upgraded. We've seen evolution and technology advances with more and more procedures being done in vascular surgery and endovascular surgery with less and less training opportunities for trainees. It is very expensive to train a doctor, and it's even more expensive to train a vascular surgeon. So I want to draw some similarities between endovascular and laparoscopic surgery. They're both done through small incision with less pain, early mobilization, and huge benefit to the patient, but they're both very expensive to practice, learn, and implement. If you look at the operating theatre, again, the skills are fairly similar. You're working in a two-dimensional environment, looking at a monitor, compared to three-dimensional surgery, which is open surgery. So there's some similarity that I want to draw between skills acquisition in laparoscopic and endovascular surgery. But first, what's the evidence? So this is a systematic review which was published just a few weeks ago in November of 2022, looking at the role of simulation-based training in vascular surgery. And please accept my apology, because I know the author is a urologist. So over here you have a laparoscopic surgeon and a urologist telling vascular surgeons how to train. These are different procedures that were researched, and you can read more about it in that paper. Fortunately, endovascular surgery and laparoscopic surgery, they both lend themselves to training by simulation because you're operating in two dimensions. So let's look at what lessons we've learned from the evolution of laparoscopic surgery rather than reinventing the wheel. There are internationally agreed standards for training which are now norm in aviation, but nationally and internationally we yet to have any consensus in surgical training. What I've shown in this slide is a pathway which is more or less accepted but has a lot of variability in practice. This slide shows the evolution of laparoscopic competency-based training across different specialties, as you see in West, in urology, gynecology, in laparoscopic surgery, and in robotic surgery. These programs are now well embedded in the surgical training in the West. And I just want to draw your attention to this fundamental program which was established by SAGES and ACGME in USA. The goal of the fundamental program was to harmonize the surgical skills training and teach a standard set of skills to everyone so as to standardize training and improve outcome. In 2004, Fundamentals of Laparoscopic Surgical Training Program was launched and this is the most successful minimal invasive surgical training in the world. A decade later, in 2015, a similar program was launched in endoscopy, and today certification in both these programs is mandatory for American board certification. At the same time, in 2015, Fundamentals of Endovascular Surgery program was also developed and launched. However, this has been lost in the ether, and I don't see any integration of this in curriculum. This was the structure, and it was validated both on virtual reality simulator and synthetic model in practice. There's another example of proficiency-based stepwise endovascular training curriculum prospect, which has been tested in trial, but has not been put in practice. So we can safely say the current system is somehow not working, and we need to upgrade things and perhaps take advantage of technology to enhance surgical skills and training. Augmented reality applications have been used and tested in open surgery, robotic surgery, including endovascular surgery. This is an example of vascular major trauma and limb reconstruction using augmented reality. All this technology is expensive. This is the first paper that I came across in vascular surgery, which is using smartphone. As you can note, this is just a single author. Again, I happen to know the author. He is a surgical registrar in the UK who has developed this technology using patient data and digitize that. And what you see on the screen is just a smartphone screen capture with the patient data which has been fed into the computer. So this is emerging and coming. Virtual reality, on the other hand, a bit more expensive, but very well researched. You get a host of data from virtual reality simulator for benchmarking, training, and assessing competency. Angio-Mentor is the most highly validated endovascular training simulator. What you see on the screen is a variety of procedures that you can learn. You can not only learn, you can input the data from your angiogram, patient angiogram, and practice and customize training, and even rehearse before doing it on a patient, either on a 3D printed model or by a simulation to look at the outcome that you will get. Now coming to robotic surgery, Tom Cruise is out of job because we no longer need fighter pilots. It's a desk job. You have somebody sitting on a desk remotely controlling drones. We don't need fighter pilots for this purpose. So how does this relate to a vascular robotic program? CorePath is an example of vascular robotic endovascular surgery. And there are perceived benefits to the patient of more accuracy in stent measurement and placement. But as an alien, what I was really surprised was the immense benefit to the staff. As you do more and more advanced endovascular procedures, you are exposing yourself to radiation. With this robotic surgery, you are sitting remotely in a shielded environment. And it is claimed that you protect yourself more than 95% from exposure to radiation. And what is the effect of the radiation? We all know. Increased risk of cataract, various cancers, and potentially reduced strain and fatigue if you sit and operate. We completely neglect our own personal physical health. So what can we learn if you want to implement robotic training program? Again, look at gynecology, urology, general surgery, etc. Fundamentals of Robotic Surgery program was developed over 2 years with 80 experts from different specialties over 4 consensus conferences to develop this curriculum. This is now widely available, and you can simply replicate this and use it as a template. Here's another example of robotic curriculum in urology by the European Urology Association. CorePath Vascular Robotic program is also available as a template for adopting and using it in practice. So are robots the future of education as well? My answer is yes, because of the potential of adaptive learning. And what we mean by adaptive learning is it's learning using computer algorithm as well as artificial intelligence, which is tailor-made to adapt to the learner's need. Now, if I look at other specialties and see which units have been successful in implementing this in the practice, there's only one single message that emerges, is having a collaborative mindset at the heart of the center of the centers practicing and implementing this surgery. Finally, I'd like to draw your attention to the 12 fundamental commandments of vascular surgery. This was published in Annals of Royal College of Surgeons of England in 2009. And the second commandment for vascular surgery is thou shalt not practice vascular surgery in isolation. With that, I'd like to conclude that regulatory bodies in West have recognized the importance of simulation as part of the curriculum as well as method of assessment. And surgical simulation has shown in other specialties to be an effective way of ensuring proficiency-based skills acquisition. To ensure that vascular trained surgeons can perform uniformly to a high standard, we need to provide more opportunities for simulation and technology-enhanced skills acquisition. Thank you.
Thank you very much, Professor Patel, for this informative lecture. I just want to announce that the lecture of Dr. Zafar Kamal was cancelled because he could not make it. It's my honor to introduce the next speaker who made really the whole way from Los Angeles to Dubai to present this lecture about vascular and vascular fellowship guidelines and requirements. He is the head of vascular program in Cedar Sinai, well-known hospital in Los Angeles. Thank you.
Thank you, Bernard. Thank you for the invitation to present at this great meeting thus far. So, I was tasked with talking about the endovascular and the vascular fellowship requirements and guidelines. So, some of this will certainly overlap with Dr. Patel's last talk and some of the deficiencies that we have. So, these are the definitions of vascular surgery from our graduate medical education body, the ACGME up top, and the European equivalent down below. And it's good to see that I think around the world we're on the same page of what we're trying to teach. But as you heard throughout, there's certainly some issues that lie ahead. Certainly within the US, we have an increasing aging population, certainly increasing rates of comorbidities, specifically diabetes. In the US, fewer people entering medical school, certainly fewer students entering surgical fields, and perhaps earlier retirement ages. So when you look, certainly in the US, there's going to be a significant shortage of vascular surgeons in the several decades to come, and I suspect that's going to be true worldwide, based on the prior slide. And just as in the US, I'm sure this is an issue worldwide, it's not just numbers, but distribution as well. And so in general, it's predicted that you need 1.4 vascular surgeons per 100,000 population. And in the US, we reached this only at about 70%, but as you can see from this map, several states fall well short of this. And in part, you can see the dots here are their training programs, and these are centered on the coasts and the big cities, and far less in middle America. And why is this important? We know that with variation in access to care, this leads to variation in rates of things like revascularization or treatment of aneurysms, and subsequently then increased morbidity and mortality with these. So if you look at the US in terms of training programs, they're about a little bit higher than this number here, but 180 to 200 vascular surgeons added. We have sort of two main pathways. One is the conventional fellowship, of which we have just over 100 programs, and then integrated residency, where medical students will enter straight from medical school, and that continues to grow, and currently we have about 64 programs. So these two different modalities, if you look at the integrated programs, so again, straight from medical school, you need to have 30 months of devoted vascular surgery, 18 months of core surgical training, most of which are done in general surgery. The remaining 12 months can be done in a variety of different fields, including additional vascular surgery. Of note, your entire last year must be performed on vascular. The early specialization program is a bit of a zebra. We don't use this much, but people that know they want to enter vascular after 4 years of general surgery can do so. They're eligible to be boarded in both general and vascular surgery. There's no conventional 5th year of general surgery that you would normally have. And what we have at our institution is a conventional fellowship. So this is 5 years of general surgery followed by a 2-year fellowship. These need to be 24 months in total, no more than 6 months of research. You don't actually need nowadays to complete what you heard about just in the last talk, the surgical principal exam or the general surgery qualifying exam. You do need to take, which is our primary ultrasound interpretation test, the RPBI test, before the vascular surgery board. So this, I don't know how well this appears, but this is a variation in sort of training requirements in the EU, and there's a variety of different pathways that you can do, different sort of iterations, how much endovascular work you need, and importantly, how you're boarded and how you're assessed. From oral test to written exam to no test at all. So in the US, and again, I think important if anybody's thinking of starting a fellowship, which we did several years ago, is that you need to have a certain core faculty. So one of these you need to have at least one faculty per trainee, not counting the program director. One of the surgeons, in addition to the program director, needs to be a board certified vascular surgeon. You can utilize non-surgeons, but really need to have sort of good rationale for this, specifically perhaps a radiologist or cardiologist with a high volume. And of note, the program director needs to have some experience, meaning more than 5 years for fellowship. So numbers, I think this is something that, it's taken a while to get to this point. This is conventional fellowship. I think probably the most important number is this top number, which in the growing age of endovascular is always becoming an issue. So 30 intra-abdominal open cases. And I think this is, we'll get to in the final slide, sort of an issue that people struggle with. Just as a demonstration, these are the integrated cases, so not that different. Of note, they do specify you need to have amputations as well. The numbers are a little bit higher for endovascular cases in total, but the same number of abdominal open cases. So just sort of what's actually happening, this is fellowship across the country in the US from last year. So I think again, as becoming an issue worldwide, if you look at these top two numbers, these are the national average of open ruptures and open elective repairs. But importantly, I think again, if you look at the standard deviation, there are several places where you're doing less than 2 or 3 open elective repairs over a 2-year period. In total, this is again from 2022, fellows are doing just about 700 cases. And I think just for demonstration's sake, hopefully this appears, but this is our own fellow. And you can see the pretty low numbers in a couple categories. One is extra anatomic bypass, and one is amputation. So at our institution, the orthopods and podiatrists do 99% of these. So it's important to see there's going to be variation in fellowship no matter what numbers you lay out. As I mentioned before, you do need to have non-invasive testing. The training program has to have an accredited vascular lab. Trainees have to interpret at least 500 exams and then successfully pass the written RPVI test prior to sitting for their vascular surgery boards. We're not going to belabor this, but you need to have necessary conferences, including morbidity and mortality conferences, journal clubs, and regularly organized clinical teaching in addition to this. As well, scholarly activities, so fellows don't need to do any of these things, but they certainly should participate in clinical or laboratory research, and the program has to have some record of participating in at least 3 of these, meaning research, quality improvement, etc. I think curiously, just there's some other requirements within the US that you need to have, fellows need an office space, they need to provide a certain software, access to food, sort of interesting things that are actually written rules that you need to comply to, especially with site visits. Evaluation, I'll skip through this, this becomes an issue just, as we saw in the last talk of how to sort of assess competency. And I think again, I'll sort of piggyback on Dr. Patel's talk, that there are going to be some challenges. And, in this day and age, work hour limitations, expanding a knowledge base, new technologies, as we've seen, even in the world of maybe fistula work, decreasing number of open cases, and then continuously there's going to be a generation gap between faculty and trainees. So one of the biggest challenges that I think we're facing in the US and worldwide is open abdominal linear gainers repair. It's sort of been the defining procedure of our specialty. I think a reason a number of students will end up going into our field is they see one case and decide this is the greatest thing ever. But the reality is we're doing much less and less of this, and the cases we're doing are much more complex. It's a little bit dated study, but if you look, and this is trainee volume, and if you look in the less than 5 to the far left of this, so about 40% of trainees are finishing with less than 5 open gainers and repairs during their training. So how are you going to overcome this? And I think, again, as to Dr. Patel's point, so we could lower the requirements, we could have mini fellowships in high volume centers, we could have away rotations either within the country or internationally. And then certainly training courses and simulation are going to play a role. And just to finish a little bit with simulation, so again, competence is the goal here. So it's not necessarily doing a bunch of cases, and we've used that in the past as a proxy for clinical expertise. But really it's, understanding the procedure, being aware of complications, thinking about issues that may arise, communicating with the surgical team, clinical reason in terms of decision-making, teamwork, and then problem solving. So when you think about open aneurysm repair, there's certainly some alternatives that trainees can get exposed to. So in terms of the actual exposure that we think about, myself, I do 1 to 2 spine exposures a week, and that's a great means of doing retroperitoneal exposure again and again and exposing the aorta. Thinking about retraction, reconstruction, we have pulsatile perfusion models that may simulate sewing, although not perfect. And then troubleshooting and intraoperative decision-making, thinking about oral board type questions and team-based simulation, not just sewing A to B. There are a number of different flow models. This is just an example of one of them, which is relatively good about simulating what it's like at least to sew in a hole. Open simulation is great. It allows for different practice, exposure to rare, complex situations, but it's costly, it's resource intensive, and certainly time intensive. And we previously showed in this study that it's important that you don't just have residents or trainees go and do it, that you actually have to be involved, and faculty dedication really is the thing that makes a difference in terms of performance. And it's not just open aortic surgery. As we know, endovascular techniques have really taken over from bypass, and as well, bypass outcomes is dependent on surgeon volume and surgeon expertise. So in terms of vector simulation, it needs to really be integrated continuously, has clearly defined outcomes. Learners need to do these things repetitively, and it's got to be specified for certain levels. We do a bit of this, but sort of not as well organized as we'd like just yet, but I think it's something certainly to incorporate. Just a quick note on our fellowship. So if anybody's interested in starting a fellowship, I'm happy to share sort of our knowledge. We started it just in 2018. The number of applicants has really grown immensely. We're applying for we have a second position approved and plan to add additional teaching site. Again, I'm happy to share sort of our curriculum and so forth whenever. So certainly there's going to be an ongoing need for vascular surgeons internationally for the foreseeable future. The education of fellows needs to be diverse in pathology as well as operative approaches, and simulation should certainly be considered as an adjunct for certain low-volume procedures. Thank you again for the invitation.
Thank you very much. Thank you very much for coming from Los Angeles all the way. It's got 2 very important talks about the education and teaching in vascular specialty, and I'm sure it's opening a lot of topics for discussion. Let us just finish this section. Let me introduce Dr. Michel Trufa. He is not a surgeon, he's not a radiologist, he's not a cardiologist. He's an angiologist. It's quite a strong specialty in Europe, and he's going to talk about endovenous laser.
First of all, thanks for this invitation. Dear colleagues, I present total endovenous laser.